Sound is not coming.
Music.
Music.
Ma'am, let's start.
No music. Shall I start?
Yes.
Good evening and happy Doctor's Day to all the dignitaries and delegates who have logged in here. Today we are entering the 5th year of this academic journey intended to create interest in busy practitioners' mind. For the latest development, research, and management of common conditions which we treat in our day-to-day practice, especially a pediatric practitioner in periphery. Now I invite our academic guru, Dr. Mahesh Mohite, for opening remarks. Over to you, sir.
Thank you, Dr. Chitra Madam, for this wonderful opportunity. Actually, it's really amazing looking at the journey. I'm really proud to say that my Raigad branch, especially Jay, Dr. Jay, as an initial convener and kind of it was his basic idea under the leadership of then Maharashtra State President Dr. Hemant Gangolia. And it's very kind of looking back 5 years, a particular activity to run back to back for 5 years, I know how challenging it is, especially a activity like journal. Okay, I mean, I'm sure there are few hardcore followers and there are few hardcore non-followers as well. So on that background, the whole credit goes to this team along with Dr. Chitra Madam and Dr. Nimay Mohanty. Dr. Mohanty sir has joined, Dr. Chitra Madam.
Yes, yes.
Yeah, I have joined. Thank you.
Hats off to them, the way they have carried forward this activity. And believe me, every times, in spite of all these difficulties, there has been attendance touching most of the times around 40 to 50 people or kind of delegates. So wonderful activity. I hope that the future presidents also will continue with this activity because this is one of the, I would say, most hardcore academic activity, a research-oriented academic activity, which very few of the branches are running it. And thanks to Maharashtra IIT, the subsequent president, secretaries, to continue running this activity. Thanks to the subsequent presidents, all of them, three, four of them, and presently Dr. Sanjay Pakmode sir is a president of Maharashtra. So thank you very much for being with this activity and encouraging the team to continue with this activity. I'm sure this will go on for on and on for many more years, maybe decades like that, which will be very helpful to the members of the Maharashtra IIT. Thank you very much.
Thank you, sir. And now I'm happy to invite my co-moderator, who is really working very hard.
Chitra, sorry to interrupt.
Yeah.
President-elect Madam Neelam Mohan has joined.
Yes,
Welcome,
yes, sir. Yes, sir. That she is being invited now by Dr. Neha.
President is there. Khadkar is there.
Yeah, very nice. Dr. Neha, for the further proceedings.
Yes, thank you, ma'am. Good evening to all the respected dignitaries, my seniors and colleagues. I, Dr. Neha Singh, on behalf of Maha IP and Raigad IP, I welcome you all to the 1st of July. Yes, today is Doctor's Day. Happy Doctor's Day to all of you. And today is also the birthday of our journal journey, the 4th birthday. I welcome Central IIP President, respected Dr. Vasant Khalatkar sir, for his blessings. Over to you, sir.
Good evening, all. First, I wish to you all that happy Doctor's Day. Really, it's a great day and great thing that it's a birthday, 4th birthday, and Maha AP is doing such academic work that is a continue in association. So, I really want to appreciate the work done by Maha AP and congratulate to team Maha AP, President, Secretary, along with the organizer. It's a really enthusiastic though showing that shows the strength of that 5,500 members are. Welcome, Dr. Neelam, for MahaAP this event. Really, it's a great that you have also joined, and I know there is one more program by 9:30, but still, Neelam's info is really good. We saw it. Thank you, Neelam, on behalf of MahaAP. I am serving not as the president. Dr. Sanjay Pakmode, Dr. Amol, Dr. Chitra, and all Navi Mumbai team, they are doing really hard work for this. I wish all the best. Let us continue this journey. In the first episode, I told that this is a new thing we have got because see, when we were student, it was the best thing because we were not getting any references 30 years before on internet or it was not there. So we have to go to library and search for all these references and journals through in the library, and that we have to present by writing or click on that Excel sheet. Nowadays it's easily available, but still his physical journey of virtual journey, sorry. It's really great thing. It's from the mind of MahaAP. Once again, I congratulate you. Thank you. And once again, wish you happy Doctor's Day. Thank you.
Thank you, Vasant Khalatkar sir. Thank you for all the blessings and encouragement. Now I welcome Central IIP.
Thank you, sir, for joining.
Lovely Dr. Neelam Mohan ma'am. Over to you, ma'am.
Thank you so much, Neha, and thank you, Chitra, for personally calling me up. Respected Dr. Vasant Khalatkar, मतलब महाराष्ट्र मुंबई का क्या कहना, वसंत भी आपका, मुंबई भी आपकी, दोनों, they are doing so great that we are so proud of the good work being done. And today I want to release, I don't know, secret, Dr. Vasant. Should I release here or 9:30 I should release? Well, there is a surprise for Dr. Vasant.
You can.
You people will be proud, and the first one to know that Dr. Vasant today on this auspicious day of July 1st has been nominated for the Dr. B.C. Roy Award. So heartfelt congratulations, and all of you can clap.
Congratulations, sir. Congratulations.
And he got it for social service. So he got it for social service, which is so true, as we all have seen that IAP presidents are so much into social work. And I can only say I'm infectious. My infection has lago to Dr. Vasant. Now I can proudly say both of us are. So I'm so happy and so proud that we are doing. And also I'm so happy to be here because Maharashtra and Mumbai, they have taught us academics, they taught us IAP, they taught us togetherness, they taught us so many things. And we are truly proud. We are just emulating what you people had taught us when we were young. The heritage, the culture which you all carry in academics and IAP needs no words to be told to you all. You've seen your seniors, you've seen it flowing in your blood, you've seen it flowing in your ears, and that's how. And each one of you, whether it's Pak Pune, whether it's Amol, whether it's Neha, whether it's Chitra, whether it is Joshi, whether it's Jay, the way you all work is truly applaudable. Sometimes I feel पता नहीं कौन सा पानी पीते हैं, अब वो शेक भी पीना शुरू कर दिया, देशमुख भी पीना शुरू कर दिया, और तो और बेचारा शरीफ हमारा रमेश बजानिया, उसको भी वही पानी पिला दिए. अब वो भी वेस्ट की बात, वो भी उतना ही काम करता है जैसे वो. And I think I need to be more and more with you all because आपकी ये बीमारी, infectious बीमारी, बहुत ही अच्छी है लोगों के लिए. और it's not about the election, it's not about this year. मैं सिर्फ एक ही बात कहूँगी आज के दिन, मुझे भूल मत जाना, हमेशा अपने साथ ही रखना. And wishing you all the two people from the Mumbai Raigad branch and Dr. Moite, who was one of the first people from this branch who got popular. Congratulations to you and to everyone. And Vasant ji, दिल से काश आप पास होते तो मैं हक कर पाती, लेकिन शायद लोग अच्छा नहीं मानते, बट दिल से मैं आपको बाहों में ले रही.
Thank you, madam. Thank you. Thank you.
Many, many more.
नहीं,
अतनु
it's
जी भी ज्वाइन कर लिए. देखो हमारा टिगरू राजा बोलते हैं उसको. Tigru Raja is also on the scene.
it's an honor for IAP, madam.
Yes.
Madam, it's not mine.
Yes,
It's
it
IAP.
is indeed IAP because your social work is great, sir. Bless you, bless you, bless you with
Thank
more
you,
and
thank
more
you.
awards and happiness and friendship like you carry, and the what Maharashtra expects from you, the same the whole country expects from you. और मेरे लिए तो यही है पूरे मुंबई रायगढ़ को मुझे भूल मत जा.
Thank you. Yeah.
Okay then, over to the host.
Thank you, ma'am. आपको कभी नहीं भूल सकते and we are not.
नेहा लॉक किया जाए ये रिकॉर्डिंग, बिल्कुल ये वाली लाइन बिल्कुल लॉक कर देना. ठीक.
Sure. Okay. Thank you so much, both of you, Vasant Khaladkar sir and Neela Mohan ma'am, to finding out time from your busy schedule and
और
joining us.
आपको 4 साल अपनी जर्नल की मुबारक हो. अब और वो यूथ और एडोलेसेंट में जाए और आप और ही सब जगह अपनी जर्नल बिछाए.
जरूर.
madam.
Neha, Dr. Atanu.
Yes, sir. Now I request National's IAP Treasurer Dr. Atanu Badra sir to say a few words to us.
Thank you, Neha. I had not joined to tell anything. Actually, I had joined to silently get into when history is being made. For such a long time, this journal is having this journey. So we thought we would inspire all of you. Though I think you're already full of inspiration, but still Dr. Vikas and Dr. Ajay are doing a great thing. From a small branch you have developed into such an academic importance. And thanks Dr. Mahesh Mahinte sir and Dr. Nimai Mohanty sir. Nimai Mohanty sir is one of my mentors in IAP. So thanks for continuing this great academic work. We are there with you, and I hope many people of us, we spread the message across the country so that many can take the advantage of listening to your
Dr.
presentation.
Mohanty, apologies. I missed you. I saw you just now. Apologies.
I was just going to speak to you. Thank you very much for joining. And Dr. Khaladkar also. So kind of you.
Thank you, sir. Thank you, sir.
Thank you, Atanu sir, for joining.
Modi sir and well, we are really fortunate to have two Pichi Roy awardees today amongst us. So Dr. Vasant sir and Dr. Neelam sir also. So I think it's a great honor for IIT.
Thank you, sir. Heartiest congratulations, Vasant sir, and thank you all of you for joining us. And now let's listen what the history was journal journey. And so now I invite Dr. Hemant
Gangolia sir. Gangolia sir first.
Neha, two words from Neha.
Yes, sir.
Just few words from Bajania sir.
Oh, thank you, Sanjay sir.
Yes, I wanted sir to listen the history, and then I wanted to.
No. Then we'll go according to flow only. I'll listen to history first. Yes.
Yes, sir. Okay. Over to Gangolia sir.
Thank you very much, madam. And good evening to all the respected dignitaries on this Zoom dais, office bearers of CIP, office bearers of MahaIP, office bearers of Raigad IP. Neha, will you share my PPT?
Yes, sir.
So just going through a small, we'll just spare a few minutes how this idea got into the minds, and because it's a very interesting to note. So make it full screen. So when there are tears, you are a shoulder. When there is a pain, you are a medicine. When there is a tragedy, you are a hope. Happy Doctor's Day to each one, everyone. Next one. So how this journey started. So thinking about this journey, we are entering into the 5th year. Next one. So it was a fine day, Sunday morning, when there was one person with flight of ideas and one person with a vision, and both having a talk on the phone, because that was just post-COVID and kuch to naya karne ka hai. What to do new one thing. So just as we were discussing our college days, we thought of, we were reading, how do we used to read journals. And that time, Jay just said to me, "Arey, अपन ये journal reading चालू करने का क्या?" And that was only 1 week ahead of this Doctor's Day, 1st of July. I said, why not? And then 1st July, let us start with this one. So these two ideas came with one vision and with one flight of ideas. And next one. So what next? So immediately after half an hour discussion, we just have a WhatsApp call with our mentor, Dr. Nimen Mohanty, as well as the Chitra Kulkarni madam. And this is a WhatsApp call image screenshot of that day when we had a call among 4 of us, how to go about it. And we just had a discussion, norms and what was in my mind. And that was crystallized by Dr. Nimen Mohanty sir. And I said, what we read in journals, it should be crystal clear within 10 to 12 minutes. So just then Nimen Mohanty sir said, I will just give you the ideas how to. So this was a WhatsApp call screenshot. So how the casual talk, I still say it was a casual talk, but some may object, Jay may object. Jay will say it was a serious talk. But I said it was a casual talk on one fine Sunday morning, and how this casual talk becomes into a phenomena of the great history. And so we notice, and immediately, next Neha. So this was a slide, first prior made by Dr. Jay Bhandarkar for the journal journey. And then we refined it. And so the 1st of July 2021 was the day when we started this journey. Next one, Neha. And this was the Zoom slide of that meeting, which was on the 1st of July 2021, when it was graced by our then Maha-AP President Jayant Pandharikar sir, Secretary Sadachar Ujlamkar, as well as Dr. Basavaraja, Secretary, and Dr. Dhananjay Shah from Gujarat graced the occasion. And also the Amal Pawar then was a treasurer of the Maha-AP, also graced the occasion. Next one. So this was the second episode of 1st August 2021. And this was the episode when Subramanya teached us how to read the journals and make the presentation for this. And that time I had just shared tidbits and bits from journals, and that was my first episode in the journal journey. Next one. So when I became president of Maha-AP in 2022, this journey, which was of district, went into the state, and across the Maha-AP state, we collaborated with IIP Raigad, and this journey went into the state of Maharashtra. So this was taken over with Maha-AP into this state program. So this was the 1st January 2022 episode. And then next, this was the first celebration of the first general birthday celebration of 1st July 2022. And this was the first birthday celebration. Next. And so at the 1st of January 2023, when the office bearers, Maha-AP office bearers changed, Dr. Ramakant Patil, then the president of the Maha-AP, secretary was only one and only one. Still he is only one and only one, Dr. Amol Pawar. And this episode was taken as a continuation process of this. And Dr. Ramakant Patil gracefully continued his program. So Journal Journey continued in the tenure of Dr. Ramakant Patil tenure. Next. And so we had second birthday celebration on 1st of July 2023 with Dr. Satish Devpujari as a guest of honor. And next, so with again change of the office bearers for 2024, it was then again Dr. Ram Gopal Sezara, then president of the Maha-AP, as well as the Amol Pawar, continuing as the secretary of Maha-AP, continued this episode of Journal Journey along with IIP Raigad into his year also of 2024. And just a word, in 2022, in 2023, it crossed from Maharashtra state to other states too. Andhra Pradesh, Telangana, Gujarat, as well as the east state also. I don't remember the name of the state. Meghalaya. So it went to the Meghalaya state also. So this was in 2024. And thanks Dr. Ram Gopal Sezara again to continue with this our episode of IIP Raigad, which is very dear to our heart, started on the Doctor's Day. And then next, so the third birthday was celebrated on the 1st of July 2024. And this was the presentation of this of 1st of July episode. And then once again, next, in 1st of January 2025, when the Maha-AP President, Dr. Sanjay Pakmode sir, took over from in 2025, he again And we are really very thankful to Dr. Sanjay Makmode to continue our episode of Journal Journey, which was started by IIP Raigad. And so with this first episode on the 1st of January 2025, today we are celebrating this episode as a fourth successful years of MahaIP Journal Journey. This is our fourth birthday and we are entering the fifth year, and I presume or I think that this will be continued for the next years to come with the MahaIP. And thank you very much for all CIP dignitaries to
नेट गया शायद इंटरनेट
If it is done, can we stop the sharing? Yeah. Over to Dr. Neha.
So we have seen the wonderful history of Journal Journey for last 5 years, and this is the fourth birthday we are celebrating today. So now I request our MahaIP President, Sir, Dr. Sanjay Pakmode, Sir, to say a few words to us. Over to you, sir.
Sir, please unmute.
You can come in. Bajania, sir.
Yeah, because we have to attend we have to attend the 9:30 meeting also.
Yeah.
So I welcome West Zone President Dr. Ramesh Bajania, sir. Over to you, sir, for your blessings.
Thank you so much, Neha, for little elaboration. I wish that you are correct in your forecast, whatever introduction you had given about myself and other dignitaries also, because president would be a distant dream. So congratulations to Maharashtra IAP along with Raigad IAP team, because to continue any academic program for a very long period, especially for this is fourth birthday, it requires Herculean efforts on the part of branch OBs and the concerned academicians, because after a certain point of time, generally people stop that activity or the interest fades. But it is very nice to see that you have expanded your wings. And today it is so relevant that we are also happy being from West Zone and Maharashtra, our beloved president. He has been nominated for Dr. B.C. Roy Award. So it's like icing on the cake. And on this occasion, I wish all of you the best, and I wish that this journal journey continue till, we are there. So every year we can be able to celebrate it. Dr. Ajay Kori and Dr. Vikas More deserves a special round loud of applause. And as said by Dr. Amol Pawar and Dr. Sanjay Pakmode, they are a great team, as said by Dr. Hemant Gangolia. So every day some or other activity, academic activity is going on, and we are really proud. So let's be, as a strong academic team, as a strong team from the West Zone comprising Maharashtra, Goa and Gujarat. And I wish all the best, and I assure my support anywhere you need it. Thank you so much. Thank you.
Thank you, sir, for your blessings. Now I invite Sanjay Pakmode, sir.
Namaskar. Respected Dr. Vasant Khalatkar, sir, President CIIP 2025. Madam Neelam Mohan, President-elect CIIP 2025. Dr. Atanu Bhadra, sir, Treasurer CIIP. And other members of the CIIP, West Zone Vice President Dr. Ramesh Bajania, sir, and Dr. Sanjeev Joshi, sir, EB 2025. And our MahaIP past President Dr. Hemant Gangolia, sir, Dr. Chandrasekhar Dabhadkar, sir, Mahesh Mohite, sir, Vishram Buche, sir. Then our Dynamic Secretary Amol Pawar, and today's the people behind this program, that is Dr. Chitra Kulkarni and Madam and Dr. Neha Singh and Jay Bhandarkar, sir, and all the MahaIP other office bearers and all the attendees. And I should not forget the name of Dr. Niman Mohanty, sir, who is the founder person of this particular activity. Now, it is definitely a very different type of activity if you consider the academic programs of the whole month. First thing, it starts on the very first day of the month. which gives a boost for the next activities and makes us ready how to get ready for the whole month's academic activities. Second thing, it coincides with so many special days. Right now, it has been said it started on the very auspicious day, that is a Doctor's Day. And now today we are celebrating the fourth birthday of the journal journey. It's a wonderful thing. Any activity which is continued for the 4 continuous year, it speaks about its quality. It speaks about its difference from the other activities. That's why every president continued. But one more thing I wanted to dwell, it is the whole efforts of the Raigad IIP, which means you get a ready-made activity on the very first day of the month, which they prepare and which they serve you on the first day, and you have to make a flyer and just circulate that flyer, and your one activity is getting done. So that's a wonderful thing. I mean, for that they arrange the means prior to the activity they do the so many sessions, and then the activity is done. So that's the real beauty of this particular activity, and I really appreciate the efforts of the Raigad branch, and I must thank from the bottom of my heart the Raigad branch for the efforts they put and for their commitment for this particular activity. And every president in future will definitely continue this activity, and this activity is going to continue for so many years, because I mean, it is definitely means nobody will. It is not an activity like this, but nobody will like, and it's a superb activity. And I request every successor presidents also to go with the particular activity, because before taking over as a presidentship, when you join the program for the last few months, then you come to know about the quality of this program, and you think this is the program to be done, which will start on the very first day of your presidentship, and also going to be done on the first day of the every month, which will be around 12 activities in a year. So that's a superb thing. Once again, I thank the Raigad IIP from the whole MAHA-IP team for their putting their efforts and doing this particular activity for so many years. Thank you. Thank you.
Thank you,
Over
sir.
to Neha.
Thank you, sir. Now I invite MAHA-IP Secretary Dr. Amol Pawar, sir, to say a few words. Over to you, sir. Yes.
Good evening, everyone. Actually, I echo all the sentences Dr. Sanjay Pakmude sir has just now told. It has been a very nice journey what Dr. Gangolia sir has told about Raigad IIP, Dr. Jay Bhandarkar sir, Dr. Nimen Mohanty sir, and the main architect behind this program, Dr. Chitra Kulkarni ma'am and Dr. Neha. Monthly, we are collaborating with them about the presenters, finding means last 3 years, and now also finding presenters, then experts. It was a very unique efforts from both of them along with MAHA-IP team. And already we are at 9:32. So always it is a time-bound program. So wish you all the best. Wish you all, both the presenters, Dr. Sachin and Dr. Aishwarya, both the experts, Dr. Mahesh Mohite sir, Vishram Buche sir, and our own Dr. Sanjeev Joshi sir, EBCIP. So wish you all the best and wish you all a happy learning, and nice to see on this platform my mentor, Dr. Shekhar Dabadkar sir, along with Mohite sir and all the team members. Thank you. Thank you.
Thank you, Amol sir. We are very delighted to have with us Dr. Dabadkar sir. We want to hear from you, sir. Over to you, sir.
No, madam, it's already late. My best wishes are with you. I always say that Hemant Ganguly and Jay Bhandarkar, they all the time bubble with some creativity. And for last 4 years, Chitra madam and you, Neha, you are doing excellent work. So please accept my compliments and my best wishes. And I'm very sure that this program will go years together. So thank you very much. Thank you very much. I will not take your time.
Thank you so much, sir. Now I invite Mahesh Mohite sir to please introduce our experts of today. Over to you, sir.
Yeah, Mohite sir, will you please introduce? Yeah.
We are our today's first expert is Dr. Sanjeev Joshi, my very dear friend, the present Central IIP EB member from Yavatmal, and he was chairperson of Academy of Neurology That's a neurology chapter of Indian Academy of Pediatrics in 2024. He's an ex-national secretary, AOP prior to that, then chairperson of the Vidarbha PDCon 2023. He has got so many accolades, actually, the list will go unending. He's a wonderful, very enthusiastic, very active IIPN from Vidarbha, very prominent IIPN from the Vidarbha zone. So, welcome, Dr. Sanjay. As an expert on this, and as I said, he was a secretary and president of the neurology chapter, so he's a perfect expert for this session where both the sessions are related to either intensive care or neurology. So, welcome, Dr. Sanjay.
Thank you, Mahesh.
The second expert.
Yeah, display the second expert, please. So, the second expert is another giant from Vidarbha, from Nagpur, Dr. Vishram Buche, sir. Again, my mentor, my very senior from the intensive care chapter. He was president of the pediatric critical care chapter, past president of it. He is a very prominent personality on the pediatric critical care chapter, critical care. He is a pediatrician and senior pediatrician and pediatric intensivist from Nagpur. Welcome, Dr. Buche, sir. He's an expert of, he's one of the, he makes absolute wonderful kind of a PPT presentation, something which is benchmark in our critical care chapter. He is expert on fluid electrolytes and ABG. He has delivered multiple number of kind of talks on that topic, and we are all fond of his talks on ABG and electrolytes. So we have really another very good kind of expert in this field.
Yeah, our
Welcome,
third,
Dr. Buche, sir.
Yeah, welcome, sir. Our third expert is none other than Dr. Mahesh Mohite, sir. May I request Dr. Jay to introduce him?
Yeah, good evening, everybody. Yes. Actually, Dr. Mahesh Mohite, sir, doesn't require any as such introduction. I can only say is a stalwart from Raigad IIPN Center. I welcome him. त्यांची फार introduction सांगायची गरज नाहीये. And welcome him on this dais. And another thing, though Gangulia sir said is a casual, there is never casual about Dr. Jay Bhandara. Ideas are already refined. हे गेल्या वेळी मी सांगितलं होतं. General generally starts 30 years back. As an undergraduate, I started this attending. I was very fond of this. With Dr. VM Medical College Hall. All senior people, thank you very much. And thank you for giving time to talk with today.
Thank you, Jay.
Neha, if you permit only one sentence regarding Mahesh Mohite, I always say he's सबका मलिक एक, रायगढ़ जिले का सबका मलिक अगर एक कोई है तो he is Mahesh Mohite. Thank you very much.
Good one. Yeah, now our presenters, Dr. Neha, can you share the slide or?
Yes.
Yeah, our presenters are also very talented people. Our second presenter is Dr. Sachin Jangam. He is from Wadia and having gold medal in his post-graduation, and now he is working in Miraz. And our first presenter is Dr. Aishwarya Gupte. She is currently pursuing allergy and asthma training and associate professor in Sri Vasantrao Naik Medical College, Yavatmal. Over to you, Dr. Aishwarya. You can share your slides and start the presentation.
Yes, ma'am.
Can you please make full screen?
Yes, ma'am. Ma'am, is my slide visible?
Yep.
Yeah. Good evening, everyone. I, Dr. Aishwarya Gupte, I'm working as an assistant.
It's not full screen yet.
Full screen.
Ma'am, it is full screen now.
No.
Madam, you stop sharing and share the full screen wala.
PPT mode.
On your desktop there will be.
First.
Stop sharing and then again start sharing. There will be two things, one with the full screen and one will be only with slides. Click the full screen wala.
Can you share the way you want?
Yes, ma'am.
Yeah. And let us start. You want Dr. Neha to share?
No, ma'am.
Yeah. Okay, good. Yeah,
Ma'am,
done. It is full screen. Yeah, thank you.
So, ma'am, should I start?
Yes, Dr. Aishwarya, you can
Yes,
carry
please.
on.
So, good evening, everyone. I, Dr. Aishwarya Gupte, am working currently as an assistant professor at SVN GMC Yavatmal. Thank you, MahaAP, for giving me this opportunity. And today I'll be talking on the journal article. The topic is hyponatremia in acute encephalitis syndrome in children, a prospective study from tertiary center in Northern America. In Northern India. So this article is from Indian Pediatrics, and the impact factor is 1.7 for 2023. The expert for this topic is Dr. Sanjeev Joshi, sir. So hyponatremia in acute encephalitis syndrome. So why is it necessary to study this topic? So because of high prevalence, it has around 25% of prevalence. Impact on severity and mortality. So hyponatremia is associated with increased mortality and longer hospital stays in acute encephalitis syndrome patients. Even hyponatremia can exacerbate symptoms like seizures and altered mental status, so potentially leading to poorer outcomes. And it is a potential link to specific pathogens. So some studies suggest that HSV1 may more likely cause hyponatremia in acute encephalitis syndrome, making it a potential diagnostic clue. The other reasons are it is a predictor of poor prognosis. So thus timely diagnosis and management is needed. It has influence on management. So identifying hyponatremia helps in guiding fluid management strategies, thus critical for improving patient outcomes. It is also helpful in understanding underlying mechanisms. So it will help to develop targeted therapies. Therefore, researchers and clinicians can improve diagnostic accuracy, develop better treatment strategies, and ultimately improve patient outcome. So the details of the journal article, the title being Hyponatremia in Acute Encephalitis Syndrome in Children, a prospective study from a tertiary center in Northern India. Authors being Nikita Diwan, Chandrakanta, Arpita Brigwanshi. They're from Department of Pediatrics, King George Medical College, Lucknow, Uttar Pradesh. The journal is from the article is taken from Indian Pediatrics Journal, and it was published in March 2025. So in acute encephalitis syndrome, it is defined as a person of any age at any time of the year with acute onset of fever and change in mental status and or new onset of seizures, so excluding simple febrile seizures. Central nervous system infections are commonly associated with electrolyte imbalances, hyponatremia being the most common. So hyponatremia, it is primarily attributed to associated syndrome of inappropriate antidiuretic hormone secretion or cerebral salt wasting. So it in turn reduces plasma osmolality, causing water to move into this intracellular compartment, leading to cellular edema and brain edema. So what is cerebral salt wasting? So it is a condition which occurs when kidney loses sodium during intracranial diseases. So pathophysiology being whether there is CNS injury, there will be release of brain natriuretic peptide or decrease in CNS sympathetic activity, which will lead to decrease in sodium reabsorption and volume depletion. So therefore causing hyponatremia. How it is diagnosed? So signs of hypovolemia are seen, dehydration markers are positive, and negative fluid balance or central venous pressure less than 6 centimeters of water is seen. The treatment being intravenous saline with fludrocortisone if needed. And what is SIADH? So it is a condition defined by the unsuppressed release of antidiuretic hormone. So pathophysiology being this increase in the ADH, which will cause increased water reabsorption in renal tubules, therefore increase intravascular fluid volume, which will lead to hyponatremia. So in the diagnosis, there will be absence of hypovolemia, normal hydration markers, and central venous pressure will be more than 6 centimeters of water. the treatment of SIADH is fluid restriction. So the aim of the study is to assess the prevalence of hyponatremia in children with acute encephalitis syndrome and its impact on outcome and differences in clinical and lab findings between cases with and without hyponatremia. Study design, it is a prospective observational study studied for 18 months period, and it was conducted at Department of Pediatrics, King George Medical College. The inclusion criteria were children of age 6 months to less than equal to 12 years, presenting with acute fever that was less than 7 days duration and neurological symptoms, including new onset seizures and or altered mental status and duration of altered sensorium being more than 12 hours. Exclusion criteria were patients with febrile seizures were excluded, pre-existing neurological conditions, they were excluded, non-infection CNS insults like stroke or epilepsy, they were excluded. On the patients on chronic medications associated with hyponatremia like carbamazepine, valproate, they were excluded, and children with certain demyelinating syndromes. And sample size, it was calculated assuming the prevalence of hyponatremia in children with acute encephalitis syndrome, and it was calculated as 200. So the history, clinical examination, and routine laboratory testing was done, and serum electrolyte samples were done daily for 3 days. Serological testing was done for specific diseases, CSF for viral panel, and neuroimaging and CSF NMDA antibody testing was done for suspected ADEM patients or autoimmune encephalitis patients, and if it was positive, they were excluded. Hepatomegaly was diagnosed through palpation and was confirmed with ultrasound imaging. So the management, in the management, dextrose normal saline was given as maintenance fluid to all the patients, and patients who had hyponatremia, confirmatory testing using 2 samples were taken 12 to 24 hours apart. So in this, hyponatremia was categorized as mild in serum sodium level 130 to 134 milliequivalent per liter, moderate in which serum sodium was 120 to 129 milliequivalent per liter, and severe hyponatremia in which serum sodium was less than 120 milliequivalent per liter. And hyponatremia was classified as cerebral salt wasting and SIADH and miscellaneous causes. So in this, 2 groups were made, in a systemic group and neurological AES group. So in systemic group, myalgia, rash, bleeding, respiratory issues, shock and hepatitis, and increased creatinine in patients were taken. And in neurological group, pure neurological patients were taken. So after this, outcomes were assessed based on 1 month following discharge using the pediatric modified ranking scale, MRS. It was classified as favorable if the score was 0 to 2 and unfavorable if MRS was 3 to 6. So statistical analysis was performed using SPSS version 23 and R version 4.0.2, and descriptive statistics were calculated. Chi-square test for categorical variables were calculated, and t-test for continuous variables. While in univariate analysis, p less than 0.1 was taken as statistically significant, and in multivariate analysis, p less than 0.05 was taken as statistically significant. So according to the results, 234 children were screened, but 34 were excluded for various reasons, and 200 were enrolled. So their clinical parameters, laboratory parameters, and outcomes were compared. So in which scrub typhus being the most common identifiable cause of AES, followed by dengue, chikungunya, and Japanese encephalitis. And acute encephalitis syndrome with or without hyponatremia, in this, hyponatremia patients were 49 in number, that is 24.5%. The patients with no hyponatremia were 151 in number. And in the hyponatremia group, based on severity, mild hyponatremia patients were 34 in number, and moderate was 13 in number, and severe hyponatremia patients were 2 in number. While based on etiology, cerebral salt wasting was maximum, that is 95 in number and 47.5%, and SIADH was 35 in number, 17.5%. So hepatomegaly was more common in acute encephalitis syndrome, with hyponatremia patients, and hyponatremic patients also had elevated blood urea, raised creatinine, decreased albumin, and decreased serum calcium. So the outcome of this of the children with acute encephalitis syndrome in relation to hyponatremia in this, the in-hospital mortality was in 12 patients out of 49 with hyponatremia. So that was 24.5%. And the prolonged hospital stay was also more in patients with hyponatremia, 53.33%. And the favorable outcome at 1 month follow-up was 13 in 13 patients, while unfavorable outcome was 17 in 17 patients. So the profile of children with neurological and systemic acute encephalitis syndrome, in this, the proportion of hyponatremia, the p-value was less than 0.001, which was significant. Hepatomegaly value was 0.052, and the outcome was also significant, that is less than 0.001. So in this study, 24.5% of children with AES had hyponatremia, with most cases as mild. Mortality rate for children with hyponatremia was significantly higher. That was also 24.5%. And in another study by Ekambarnath et al., higher occurrence of hyponatremia was reported and was linked to herpes encephalitis. In this study, hyponatremia was linked to higher mortality and prolonged hospital stay along with unfavorable outcomes during follow-up. So in the study by Das et al., also he noted increased mortality with hyponatremia. In this study, strep typhus was the leading cause of acute encephalitis syndrome, followed by dengue, chikungunya, and Japanese encephalitis. While in the study done by Bej et al., they reported enterovirus as the major encephalitis, causing 50% mortality rate, and Kakoti et al. Reported 37.9% were due to Japanese encephalitis and 62.1% were due to non-Japanese encephalitis. And 1 month follow-up showed 43.3% of hyponatremic children had a favorable outcome and 56.7% had unfavorable outcome, while Hitachi et al. Found 21.6% unfavorable outcome in encephalitis. So the limitations of this study, it focuses on a single tertiary care hospital, so may not reflect on the overall prevalence. Some children received inappropriate fluid therapy in the form of NS, DNS prior to the hospital arrival, thus disrupting electrolyte levels and causing hyponatremia. And due to financial constraints, neuroimaging and other tests for autoimmune encephalitis were not possible in all the patients. Herpes was not identified as a cause in this study, so it may have influenced hyponatremia rates. And lastly, what this study adds, so presence of hyponatremia in children with acute encephalitis syndrome predisposes to higher mortality and prolonged hospital stay and unfavorable outcomes. So it should be taken as a warning sign and be extra vigilant to deal with the sodium imbalance to prevent mortality and adverse neurological outcome. And pediatricians at all tertiary and peripheral centers should immediately identify the imbalance and take immediate steps for further management. Thank you. Thank you so much.
Yeah, thank you so much, Dr. Aishwarya. It was very lucid presentation. Can you please stop sharing the slides?
Yes,
over to expert Dr. Sanjeev Joshi, sir.
First of all, very happy Doctor's Day to all of us. My humble salutation to the team Raigad for this amazing journey of last 4 years and still continuing with the same vigor and enthusiasm. Of course, I cannot name each and every person from Raigad because you all are in my heart. So, heartiest congratulations from my side to team Raigad. At the same time, Maharashtra IP has a wonderful collaboration for this academic activity. So hats off to all the past presidents, the president, the present team, Dr. Sanjay and Dr. Amol. Then coming to this today's journal article, hyponatremia is one of the comorbidity which will again contribute to increase in the neuronal insult. And it is well it is an established fact that whatever damage or whatever sequelae occur after an acute neuronal injury, the etiology could be anything like infective, inflammatory, or traumatic. It is not a primary insult, but it is an ongoing secondary insult which is responsible for the long-term prognosis. And of course, hyponatremia is one of the contributory factors for increasing in the cerebral edema. So, this study stage is almost 25%, whatever this prospective studies has mentioned, 25% of the hyponatremia. Of course, as Aishwarya has pointed out in the last slide, inappropriate administration of hypotonic solution before the child reaches tertiary center is one of the common cause. Number two, what type of osmotic agents were used, whether it was mannitol or whether it was a hypotonic saline is not mentioned in this study. If at all, mannitol was used in a liberal way, of course, you will have to have a strict vigilance on the sodium level. Another thing is, she has nicely depicted the pathophysiology of CSW and what you call it, SIDH. Of course, the clinical parameter being that a CSW child looks dehydrated as compared to SIDH. And one interesting fact which I could see that, or rather, I will not agree to it, that when you talk about acute encephalitic syndrome as a standalone neurological disease and a part of systemic illness, so if at all you have a systemic illness like scrub typhus, which is very prevalent in this particular area where from which the study is coming, you will always have an associated liver involvement, associated hyponatremia, and associated increased those parameters like higher BUN and higher creatinine. So in my opinion, it would have been the vice versa. Systemic acute encephalitic syndrome would have more amount of hyponatremia as compared to the standalone one. Another thing, when we talk about acute encephalitic syndrome as per the 2006 definition of WHO, it doesn't include only the infectious etiology, it includes the para-infectious, post-infectious, autoimmune, toxins, and everything. So why, if the CSF was showing NMDR positive, it was mentioned by Aishwarya that those cases were excluded. I think it would have been a more rational to include whatever etiologies of acute encephalitic syndrome they have encountered, and they should have included all those kids which are not having an infective etiology also. Because to your surprise, now the number one etiology of acute encephalitic syndrome is no more viral infections in our country. The autoimmune and the post-infectious conditions like ADEM and MOGAD, they have already surpassed the infective etiology. And of course, there is always a demographic influence on the etiology. So the important thing is, hyponatremia association in acute encephalitic syndrome is very well known to us. This study, what the important message this study gives is that whichever factor which will potentiate the secondary neuronal injury should be addressed during the supportive care. So the importance of supportive care is immense in the management of acute encephalitic syndrome. So this was all the comments which I wanted to make, but I think my dear friend, my mentor in critical care, we have a strong union since early 90s when we used to attend conferences as a young pediatrician out of the institute. My dear friend Mahesh will again highlight to my comments.
Yes,
Or you will
over
add
to Dr.
things.
Mahesh.
Yeah. And it is
Sanjay, I
always
like
a
your one
feast
very
to talk to Mahesh. Whenever we interact 10-15 minutes, I always have some take-home messages from Mahesh.
Thank you very much, Sanjay. I like your comment, and which is really a wonderful thing that we are moving the Western way where infections are being replaced by immunological problems in all the fields. So though so far we have been calling it viral encephalitis the most important cause. In fact, when we passed out, then we used to say bacterial meningoencephalitis is very common. Then the phase of viral, and now we are rapidly moving towards immunological problem. But about related to hyponatremia, we need to understand the basic concept in intensive care. Hyponatremia or hypernatremia is not a sodium abnormality, it is a water abnormality. It's either dilution or concentration. So inadvertently you're losing a lot of water or you're retaining a lot of water, which in other way, same amount of sodium, in case of more retention of water will make hyponatremia, and same amount of sodium with loss of water loss will cause hypernatremia. So we are essentially having a problem of water and not sodium. Sodium is just kind of a surrogate. Most of the times, I would say. I mean, very rare exceptions where sodium is a problem. It's water which is the problem. And these two pathologies which you highlighted, SIDH is nothing but excessive retention of water, and CSW is excessive loss of water. And they are primarily hormonal problems, hormonal imbalances secondary to encephalitis. When I say SIDH, the name suggests inappropriate antidiuretic hormone secretion, which will have antidiuresis, so retention of water. Once the water volume increases, there is additional ANP secreted because of excessive water loss, which will cause atrial natriuresis. Natriuresis means sodium and water loss. In a nutshell, effectively ADH is far more stronger than ANP. That's the reason relatively far more water retained as compared to sodium, and that's how it becomes hyponatremia. In case of CSW, cerebral salt wasting, which as you said, it's a brain natriuretic peptide, natriuresis. So proportionate water of sodium and water loss. So you will have lot of water losses. In a nutshell, how do you differentiate the two? You are essentially looking at the urine output. In case of CSW, you will have a lot of urine output. In case of SIDH, there is reduced urine output. And second important, on the background of plasma hypoosmolality, in case of SIDH, you will have severely concentrated urine. And in case of CSW, you have got hyperosmolality in a CSW of the plasma on the background of more diluted urine, a lot of water being lost. So barring that,
another surrogate marker could be, Mahesh, the excretion of the uric acid. If you consider the fractional excretion of uric acid, if you correct the hyponatremia in a child with SIDH, the uric acid excretion will increase. But at the same time, if you correct hyponatremia with the CSW, it won't affect any uric acid excretion in a case of CSW. One of the surrogate marker to differentiate the hyponatremia and SIDH, because sometimes it is really difficult to differentiate between these two entities, if you agree with me at all.
Yeah, very nice. Now, shall we move to the second topic?
Yes.
May I invite Dr. Sachin Jangam, again, star performer. Over to Dr. Sachin.
Good evening, all.
Chitra madam,
Yes.
Can I leave the meeting since I have to join that CIP meeting also?
I know, sir. I know.
Thank you. Thank you for this wonderful opportunity.
Yeah, thank you.
Thank you, Sanjay. Thank you very much. Yeah,
thank you.
Thank you very much.
Good evening, everyone. Am I audible?
Yeah.
My slides are visible, ma'am?
Yeah.
My presentation is visible, ma'am?
Yes, Sachin, go ahead.
Good evening, everyone. Happy Doctors' Day to all. Today, I will be presenting very interesting article, Novel Therapies and Intervention in Sepsis and Septic Shock. As we know, sepsis is a life-threatening organ dysfunction due to infection. And septic shock includes sepsis plus mean arterial pressure less than 65 mmHg plus need for vasopressors even after adequate fluid resuscitation and lactate more than 2 millimoles per liter. sepsis and septic shock remains a major global cause of ICU mortality despite of advances in the care and use of clinical guidelines. This is a more of adult definition. So this article is basically published, a very recent article published in February 2025. It is published in British Journal of Anesthesia. And this is published by a group of Pisano et al. They all are adult anesthesiologists plus intensivist. What is new in this article? This article reviews the emerging and novel therapies which are not mentioned in survival sepsis campaign guideline. And these are not mentioned because of supposedly weak evidence, or they have published after the survival sepsis guidelines, or there is a cost effectiveness issue is there, so that they have not been mentioned in the previous guideline. This article focuses on the new evidence where they differ from the existing guidelines. And this is more of a based on the adult literature. So we'll discuss only those points which are differ from the survival sepsis guideline, survival sepsis campaign guidelines. In hemodynamics, in adult, these survival sepsis campaign guidelines recommend mean arterial pressure of target of 65 mmHg in septic shock. Instead, interestingly, this article mentions about a new concept of permissive hypotension, where they have targeted 45 to 70 mm of Hg mean arterial pressure, and it's shown to reduce all-cause mortality which are admitted to the ICU. Also, there is decreased risk of atrial fibrillation and transfusion in perioperative settings. So this strategy potentially reduces the harm from the fluid overload. It also reduces the vasopressor related arrhythmic event and tissue hypoperfusion. However, this needs to be further evaluated. I have tried to put some relevant point to the pediatric also. In pediatrics, there are no consensus about MAP target, but usually we try to maintain mean arterial pressure above 5th centile for the age, which is calculated as 45 plus age into 1.5 mmHg. This ensures the adequate perfusion of vital organs, especially brain and the kidneys, and we monitor clinical signs of adequate perfusion, and we just don't chase the number. In fluid therapy, it has become a standard to shift from liberal to restrictive and targeted fluid resuscitation, which is guided by the point of care ultrasonography and a dynamic parameters like passive leg rising and fluid challenges. This article also mentions that steroids are preferred over synthetic colloids, as synthetic colloids do more harm and they do not offer any volume reduction benefit also. Point of care ultrasonography not only used for the fluid to guide the fluid therapy, but also it helps in source control. It also identifies myocardial dysfunction early, so that we can go less on the fluid and early on the inotropes. So this is one interesting thing which this article mentions: the role of early use of albumin. A retrospective study of almost 3,000 patients in sepsis or septic shock who developed severe acute kidney injury have shown that there is reduced median time to the hospital discharge and increase in the rate of hospital discharge with greater clinical stability in those patients who have received early albumin as compared to those who have not received albumin or those who have received late albumin. So role of albumin early in septic shock needs to be further evaluated. As per fluid therapy in children, crystalloids are preferred over the albumin due to the cost and the accessibility. Balanced crystalloids are preferred over normal saline. This is a weak recommendation. And when survival sepsis guidelines about the children mentioned, there is no role of synthetic colloids. About vasopressors, as I said, these are adult guidelines. The first line vasopressor is norepinephrine, followed by vasopressin and adrenaline as a third line vasopressor if MAP target is not reached. And vasopressin they use early if the noradrenaline requirement is more than 0.25 microgram per kg per minute. It has shown to improve the outcome, also has shown to reduce mortality and organ dysfunction. Vasopressin also has shown to reduce the need for the renal replacement therapy. This one is new vasopressor angiotensin 2, which is non-catecholamine agent, has shown to improve mean arterial pressure, also reduces the noradrenaline needs, and it has shown promising result in high renin patient. But the evidence is mainly from the subgroup analysis. Again, the methylene blue and hydroxycobalamin had shown to improve MAP, where methylene blue have shown some mortality benefit in studies, but hydroxycobalamin data remains limited. Something about angiotensin 2. This is a potent endogenous vasoconstrictor which acts on angiotensin type 1 receptor. It increases the systemic vascular resistance and it functions as a part of renin-angiotensin activating system. It is used in catecholamine refractory vasodilatory shock and RAS deficient state, such as which patient who are receiving ACE inhibitors or where the sepsis is associated with acute kidney injury. In adult ATHOS 3 trial, which in 2017 showed that angiotensin 2 significantly increased the mean arterial pressure. It reduced the norepinephrine requirement, and it has shown improved survival in severe hypotensive adult. So FDA has approved angiotensin 2 use in adult septic shock and distributive shock. Pediatric use is off-label and is not well studied. Only some case reports and small case series exist, and it may be considered in life-threatening and catecholamine-resistant shock in ICU setting with close hemodynamic monitoring. About vasopressin in children, vasopressin plays a supportive role in pediatric septic shock. It is used as an adjuvant when shock is refractory to catecholamines. It is never titrated. We use as a catecholamine sparing agent. About vasopressors in children in survival sepsis campaign guideline, we do not have separate first line agent for as a vasopressor. The choice of vasopressor depends upon the clinician preference, individual physiology, and local system factors. But it does mention that epinephrine or norepinephrine should be preferred above dopamine. Epinephrine is preferred in patient with myocardial dysfunction and low cardiac output. Norepinephrine should be preferred in a condition where there is low SVR. And further vasopressors should be decided on the by the point of care ultrasonography and individual physiology. There are no clear recommendations on the inodilators. Inotropes. Though dobutamine has been standard for the myocardial dysfunction, it lacks the mortality benefit data. Even the levosimendan, despite early promise, Leopard trial and other trials have not shown any mortality benefit, but have shown higher adverse effect. So it has limited role, and careful selection of the patient and this drug in the situation is warranted. This one is interesting, which is not mentioned in survival sepsis campaign guideline. Use of ultra short acting beta blockers, esmolol and landiolol, when used in a persistent patient after resuscitation, in those patients who have persistent tachycardia, it has shown there is a mortality reduction without hemodynamic compromise in septic shock with tachycardia. Recent RCTs showed mixed outcome. Benefits is likely depend upon the patient selection, where the LVEF is more than 65% and patient having atrial fibrillation. So timing of this drug and use drug needs to be evaluated by more RCTs. About beta blockers in children, beta blockers are not standard therapy in pediatric septic shock because most of the time in pediatric practice, the tachycardia is compensatory and it may be counterproductive to use the beta blockers in the children. So its use in pediatric practice is not recommended. About mechanical circulatory support, this is also not mentioned in the survival sepsis campaign guideline. VA ECMO, this can be considered at bridge to recovery in patient with septic shock with severe myocardial dysfunction. It has shown better result with the septic cardiomyopathy who has ejection fraction less than 25%. But favorable results were also observed in a patient who has LVEF less than 35%. But this is not useful in vasoplasia alone. So there is a limited evidence and requires individualized decision making and further randomized control trials to decide the role of VA ECMO in septic shock. About mechanical ventilation, lung protective ventilation and prone positioning are well-established strategies, but there are no strong evidence on the FiO2 target. But proxy trial has shown restricted oxygen may increase the mortality. About antimicrobial therapy, nothing much different from survival sepsis guidelines, except it is shown, it tells about MRSA coverage should be included in high risk cases only. Double coverage in patient who has high risk of gram-negative MDR organism. Antifungal coverage is indicated in immunocompromised and patient with febrile neutropenias who are not responding even after 3 to 5 days of antibiotics. Daily review for de-escalation and therapy cessation should be done. And duration of antibiotics should depend upon the infection site, response to the antibiotic, and the source control. As per the survival sepsis campaign guidelines, septic shock, we need to administer antibiotics within 1 hour, which was a strong recommendation. And sepsis without shock, we need to give antibiotic within 3 hours. This was weak recommendation. But this article mentions about retrospective analysis of almost 75,000 patients who were suffering from sepsis. And this article shows that every hour delay in starting antibiotics in sepsis will increase the chances of septic shock by 4%. So prompt initiation of antibiotics even in sepsis is needed. Bolus versus continuous infusion. The survival sepsis guidelines initially recommend giving antibiotic bolus followed by continuous infusion. But recent 2 trials, RCTs, Mercy 30 and Blink 3, shows no benefit of giving continuous infusion over the bolus infusion. So no benefit of continuous over the bolus infusion. About renal replacement therapy, there are 2 RCTs, Akiki trial, ideal ICU RCT. Early RRT, that is when renal replacement therapy was started within less than 12 hours, may increase the mortality if AKI is diagnosed only by rise in the creatinine. But there is no increase in the mortality. In fact, there is reduced mortality in a patient where the RRT was started based on the urine output alone or based on the reduced urine output and increased creatinine. Between CRRT and intermittent hemodialysis showed better outcome in less severe patient in both Akiki as well as ideal ICU RCT. In survival sepsis campaign, there is a weak recommendation against RRT in septic patient without conventional indication of RRT. No preference between CRRT or IHD has been mentioned. So RRT used to manage fluid overload, which is unresponsive to the diuretics, and high volume hemofiltration is not recommended. About other blood purification techniques such as polymyxin, Eferon, HA330, Cytosorb, these have mixed and often poor quality evidence. Some of small studies suggest possible impact on the outcome of different hemoperfusion technique in patient with sepsis, but data is insufficient to draw any recommendation. About blood purification techniques in survival sepsis campaign, these guidelines suggest against the use of polymyxin for hemoperfusion and makes no recommendation for other hemoperfusion technique. Plasma exchange is these guidelines suggest against plasma exchange except in case of TAMOF. About corticosteroids in survival sepsis campaign, hydrocortisone was recommended if vasopressor requirement is more than 0.25 microgram per kg per minute. But this approach trial subgroup analysis and 19 RCTs meta-analysis have shown that the combination of hydrocortisone and fludrocortisone showed mortality benefit in patient with CAP, that is community acquired pneumonia, and ARDS subset. So Society of Critical Care Medicine and European Society of Intensive Care Medicine 2024 guidelines now support use of steroids in ARDS and pneumonia-associated sepsis. But this is a combination, not hydrocortisone alone. We have to use combination of hydrocortisone and fludrocortisone. About corticosteroids in children, the use of steroids in a septic shock is controversial. These guidelines do not recommend hydrocortisone if fluid and vasopressor are able to restore the hemodynamic stability. We may use hydrocortisone in case of catecholamine resistant shock or in possible adrenal insufficiency. The dose is 1 to 2 milligram per kg per dose 6 hourly. There are some promising interventions which are not mentioned in survival sepsis guidelines. First is external warming of a febrile patient. 2 RCTs and meta-analysis had showed reduced 28 days mortality when the external warming of a febrile patient was done, and the temperature was maintained above 37.5 degrees Celsius up to 30 degrees Celsius. This is supposed to improve the immunology. Omega-3 fatty acids, prior SSC guidelines oppose use of omega-3 fatty acids, but new meta-analysis and RTG show some survival benefit. This one is interesting drug, anizodomide hydrobomide. This is used almost in 400 patients in Chinese patient. When used along with the standard septic shock protocol, it showed to reduce the mortality, likely via microcirculation effect. Even the IV amino acids, when used in cardiac surgery setting, reduce the risk of acute kidney injury. So in summary, this I will summarize what this article mentions, the point-wise. In cardiovascular management, permissive hypotension is the new concept this article has mentioned. So lower MAP may be targeted so that there is a less chance of fluid overload, less chances of vasopressor-related arrhythmias. This article also mentions about the newer vasopressors such as angiotensin 2, methylene blue, hydroxycobalamin, and also mention about the leozomendan. It mentioned about the short-acting beta blockers may have survival benefits such as esmolol and lalendiol. It mentioned about the use of ECMO as a bridge therapy in septic shock patient with low myocardial low ejection fraction, less than 25 or less than 35%. Early RRT may be better in case of where the RRT was started based on the urine output and raise in the creatinine rather than based only on the creatinine. This article mentions about the better result with the intermittent hemodialysis. But this is only in the low SOFA score patient. There is no recommendation about other blood purification techniques in this article. This article mentions about newer evidence such as anizodomide hydrobomide drug, which can be used along with the standard septic shock therapy. Use of IV amino acids to decrease the acute kidney injury. Then again, use of external warming of the patient to maintain the temperature above 37.5 to 38 degree. This article had shown tells about we should be the FiO2 target. Restrictive FiO2 target has increased the mortality. There is no difference between the bolus or the continuous infusion of beta-lactams or meropenem or piperacillin tazobactam. In case of corticosteroid, the corticosteroid may have a role in CAP or ARDS, but this is usually combination of hydrocortisone plus mineralocorticoids. So summary. Novel therapies show promise in improving sepsis outcome. Some current survival sepsis campaign recommendation may be outdated or incomplete. We need to tailor individualized physiology-based care, and there is need for the more high quality and multi-center RCTs to validate newer data. The individualized care is the key, particularly with the fluid strategy, vasopressor choice, timing, beta blockers, and RRT. Novel agents and strategies like angiotensin 2, external warming, omega-3 fatty acids shows promise, but needs larger studies. Ongoing trials are essential to refine practice and possible update future guidelines. So take home message, guidelines are the starting point, not the ceiling point. We need to stay updated with the new evidence. Individualized care based on the patient physiology and balance between benefit, risk, and available evidence is essential. We need to be open to integrate the novel interventions and backed by emerging data. Thank you.
Thank you. And it was a extensive, elaborated study which was in adult, but Dr. Sachin, you have rightly compared it with pediatric practice and the guidelines. And this article selection was brainchild of our Maharashtra IAP scientific convener, Dr. Minas Sheikh, sir. Minas Sheikh, why you selected this article? Can we know? Sir? Okay. May I request expert Dr. Buche sir to give his expert comments about survival sepsis campaign as well as comparison of this article.
Madam, I have just added, while reading this article, I came I've gone through the future treatment and diagnostic strategy in septic shock.
Please
If
go
time
ahead.
allows, I will just go through it.
Okay.
Or should I do it it will take 2 or 3 minutes more. Is it okay?
Sir?
I think we'll first have a discussion on
Yes,
your
yes.
presentation.
I think so. Discussion is more
and
important
then we
rather
can
than
suggest the
starting.
Dr. Buche sir, please give your comments.
Yeah. Good evening, everybody. Initially, I wish a very happy Doctor's Day to all my friends. Sachin, really good presentation, good analysis you have done. You have reviewed everything, all points here. But let me tell you the key points at the start of the article. They are given all new insights can be challenged. They need a lot of research. They need a lot of recommendations to adapt the newer insights, right?
Yes.
I have read this article very much thoroughly. See, this is the article, basically adult-oriented article, and possibly the Minas is not here. He would have also accepted many things given in this article. They are not applied in pediatric practice at all, right? This is the futuristic article. So we have to look into the details of it, right? Let me come to the slide by slide and few comments on this presentation. As far as the hemodynamic management, they have suggested new things like to maintain up to 40 to 70. We use MAP as an age-appropriate MAP. Not their recommendations, they are in the adults, whereas in the children, it is rather different. Formula is given, so we adopt that. Very rarely we have a low MAP, but they have also used the permissive hypotension. This is, permissive hypotension means a low MAP. This is not at all accepted in children. You may have a temporary, for a temporary period, a low MAP, but not a prolonged one, right? Because that can definitely induce, hypotension will cause cerebral blood flow problem and ischemia. Very rarely it can be adopted for a time being in a warm shock. In children, in neonates, of course, never to be adopted the low MAP. In adults, it has written with this article also, only in chronic hypertension cases, they use low MAP. So article says 40 to 70, but we use MAP as age appropriate things. The formula is given to this. The second slide, which has talked about the fluids, again, the protocol is different in adult and protocol is different in the children. Whatever the amount they are given, we have a different regimen in this. We follow a restricted target-oriented fluid therapy. Everybody knows the fluid, how much we give, 10 to 20 ml in 10 to 20 minutes, and the maximum 40 to 60 ml in an hour's time. So this protocol, what they have given and what we adopt, there is a large, vast difference in it. But the next slide, he has given
Yeah, we use while giving the fluids, we always again make use of focus. We find the inferior complexity, I mean the collapsibility index, we follow that. That is one of the thing addition to be done. As far as the vasopressor, we start nowadays early vasopressors. We start early vasopressors, we do have, and as far as the vasopressin is concerned, is the second line of drug. Is a third line of drug apart from the noradrenaline and the adrenaline is concerned. Then you have commented about the angiotensin 2, which increases the MAP, but they have got a very limited role in pediatric practice of off-label use. Until today, there are no recommendations to use angiotensin 2 in pediatric management of septic shock. He has not commented about the methylenedione hydrocobalamin is given that, which also they are the nitric oxide inhibitors, but again, I got a very limited role and they have not been recommended in this. Very few times it has been used in the refractory shock, but again, only in the adults, not in the children. As far as the inotropes concerned, the article has given dobutamine and levetiracetam. No, there is no role of these two drugs at the moment presentation in the management of septic shock in pediatrics. Beta blockers, in a very single sentence, I'll say no role at all. No, by physiological, it may increase the cardiac output, it may increase the stroke volume, but in children, it is not useful. On the contrary, by limiting this, you may reduce the cardiac output. The patient will land up in the problem. So there is no role of beta blockers at all in the management of pediatric septic shock. Then you have and another slide, yes, as far as the steroids are concerned, it's limited role. But let me tell you, it has been used off the label or some recommendations are there, because when the septic shock is resistant to fluids and the various vasopressors, no child should die without a trial of steroids at all. Though when it is associated with adrenal insufficiency, you have to give it. But one cannot wait to get the level of cortisol, then give steroid. No, if it is required, resistant, refractory shock, you must give a trial of corticosteroids. As far as addition of fludrocortisone mentioned, no, there are no studies at all to use this drug, this steroid in the pediatric septic shock at all. Then he has mentioned next item, blood purification. Yes, cytosorbent plasma exchange, but it is mentioned in the CRRT. It's a life saving. Yes, it has a great role, but it has to be done early. Whenever there is a fluid overload is there, AKI is there, electrolyte abnormality is there, hyperkalemia is there, hyponatremia is there, uremia is there, metabolic acidosis is there, then CRRT has a great role. When to use it? Early means what? How do you define that early to use it? It all depends upon individual case. Clinical deterioration, not the particular time, and then you have to use, but it's a life-saving whenever there's a hemodynamic instability is there in the child with the septic shock. So CRRT role there is a great role. Then there are certain immunomodulation studies are there, which this article they have mentioned. So this is the futuristic article, like IL-1, IL-6. These are the good, cytosine inhibitors. We know available in our must be there a lot of intensive care friends. They are using this drug, like and the what another tocilizumab. They are using it of the label.
Yes, sir.
You might have heard also, Sachin. I mean,
Yes,
it is
sir.
there in our discussion also in the WhatsApp that they are using it. Though it is not recommended, it is of the label use. Then metabolic things like vitamin C or thiamine has been, but there are inconsistent studies at all. So I think this article is basically an adult oriented. Minaj ko to pakadna padta hai adult class nahi. It is beautiful article. Many things which they have given, it is not applied in the pediatric practice. Right? It's only a futuristic article which is telling you some insights. But in their key points, they are written everything, all things can be challenged and further research is required. This much, I think, at the moment, I turn over to Mahesh for your comments.
Yes, sir.
Thank you very much. I think Dr. Boucher sir has really very systematically taken one by one point and dissected it nicely. I just want to say one thing. Dr. Boucher sir, you and me have seen intensive care for almost more than 3 decades, 4 decades. Gone are the days in 1990, we used to say sepsis is SARS plus infection, where then we realized the plain tonsillitis also can be labeled as sepsis. From there, we moved as sepsis as SARS plus organ failure. And today, with the latest that has come, the last surviving sepsis guideline pediatric is 2020. Latest document in sepsis related is Phoenix criteria 2023 March, where many of the things are revised, though it is only on the 4 systems like neurological failure, cardiac failure, cardiocirculatory failure, respiratory failure, and hematological coagulopathy. So there almost many things are changed. Like you mentioned, Sachin, about lactate as 2, but the Phoenix criteria mentions lactate more than 5 as abnormal. So if you go into micro details, then the things are changing gradually. So what we thought 30 years ago is totally proved to be wrong today. What we are doing today, maybe after 10 years, it will be proven as kind of ancient. The science is moving so fast. So things are coming, and you will also agree with me. Whatever we have every time thought of or we performed was something which the adults performed 10 years before that. So they are definitely far ahead of us in the pediatric critical care thinking. Maybe in last about say a decade or so, we have our separate pediatric septic and ARDS guideline. Prior to that, we are following the adult guidelines only everywhere. So even for surviving sepsis guideline, the old one which you see 1995 or 2000 were all adult guidelines which we followed. So today we just looking at us because we are having more and more pediatric related evidence, and certainly child is not a smaller adult. That's the principle, and with that, what is certainly decided is less is the more. And same thing adults are following. Lesser fluid you give better, later the oxygen target better, later the MAP targets better. And for that, the amount of fluid that we push, we have come down to almost 2/3 restriction, sometimes even less than that. And that is not essential in critical child, even in the maintenance fluid that we give in day-to-day practice. Now, few things which the present science is moving ahead, like we discussed in the last session, we are moving away from infection, going for immunological parameters. So sepsis today is not actually infection. It's an abnormal immunological response to infection. It's no more infection. It's an abnormal immunological response to infection. So obviously the therapy also will move in the direction of immunology rather than hypo and hyperinflammatory cohorts. And that's where the first differentiation on 2 cohorts, whether to immunosuppress them or to immuno add them. So that's how IVIGs come into that. That's how maybe suppression, the steroids have come. You've got the cytokine antibodies, and then the removal of those by various filtration devices. So perhaps the future of science and future of sepsis is going to move early detection of sepsis, early removal of the cytokine markers, cytokine that we detect, early removal of the toxins, and save the tissue. We don't have targets today of MAP. We certainly have the targets of the tissue perfusion. We certainly have the targets of tissue functioning. Perhaps that's going to be the future. Perhaps will be in the recognizing tissue injury first, and then as soon as you notice the tissue injury, probably you are going in the wrong direction and try to revert it back. The rest, I think, many things. In practice, it will take. We are just looking at what is advanced, but what about the resource limitation that we have? Tomorrow, even everything comes in next 5 years to the to Indian continent. India itself is 4 different continents. To the class where it really matters, that's going to be taking another 1 or 2 decades further. We need to accept all those things, and that further increases the complexity of the studies. So making everything into short, perhaps what you're looking at it is something which is future for Indian scenario, maybe after 2 decades. And by that time, perhaps the science will move another 1 decade ahead. So the chase will continue. This is just kind of a, you can say, sensitizer for what we are heading for. And perhaps not to forget, AI is going to play a huge role in the future. Your genomics is going to play a huge role in future dynamics. So future perhaps will lie in something like early clinical detection, early cytokine markers, and kind of a novel biomarkers, and putting them into the known genomics of the patient. When we talk about genomics, we are having easily the DNA, the RNA transcriptomics, we are having proteomics, you've got metabolomics, and that's why it's going to be. So I won't be surprised. I hope it's before our completion of life, maybe another 30 years, all of us will be moving into the genome card and submit it to the clinician, and he will be deciding the treatment, the precision treatment. But the 10 receiving genomic people will be different, the outcome will be different. That's going to be likely future.
Yeah.
Thank you.
Yeah.
Yeah.
Mahesh, I mean, we all, what we are practicing today in the management, lot of things have come from adult trials, adult literature, other experiments, and we are following. But nowadays, our pediatric intensive care has developed such a newer and newer guidelines, and we are following that. One more important, just at the end of it, I would like to have the emerging modalities are there, which they are not given, like, futuristic talk. I mean, the resumes you are given also, like, there are emerging modalities which will detect early, which will have prediction and also the management. There are important tools, that is AI in the management of pediatric septic shock. There are two universities at the moment, they are assessing the tools, like Hopkins University and the Duke University. They have developed certain tools like TRIUS, the targeted real-time early warning system. The tool they are using, they are also using the sepsis watch and PSense. They are they are using it, the various things, the data available, how to feed it, everything is given on the net. Newer and newer modalities, they cannot be, there has a great role then in the management. That's a futuristic model, I think, in the management of pediatric septic shock. That's all my comment.
Thank you, sir. And I'm really delighted to have you here on this platform of Maharashtra IIP as well as Raigad IIP. We are very fortunate to have such a good article, then the discussion and the experts. And now may I request Dr. Samir Sadawarte for his comments. He has raised the hand.
Oh, no, I have not raised hand, but then if
Yeah,
it's there,
you had asked some question also, like
No, I asked that question.
regarding,
That is okay. That is normal. But
Yeah.
definitely, I need to some comment because if you
Yeah.
say that way, I never asked for a hand raise, but if it's there, it's fine.
Yeah.
So obviously, like predictions, they get changed every now and then. Like I remember, like when I started my MBBS time and passed it and then started residency, it was to give 20 ml blood fluid, again 20 ml, again 20 ml. Same thing for a decay, keep on giving normal saline till the sugar goes up to 200. So things get changed and things get corrected every time. And we always feel like that the time should not go ahead, it will stay here. जो अपने को हमेशा पिक्चर में, टीवी में, प्रोग्राम्स में अच्छा टाइम है, ये निकल नहीं जाए, ये समय पे खत्म हो जाए, ऐसे ही रहे, लाइफ ऐसा नहीं होता है. So time goes up, life goes on, and we realize a lot of things which we used to do previously were wrong, or we are doing it in the different way. Same thing, like suppose the cooling of the patient and making the child slightly hypotensive and having CRT going up like 4 to 5 seconds for the newborns, and we are definitely now saying yes, this is a true treatment methods happening. So at some point something has been started, something has ended, and the new thing has started again. So we should not restrict ourselves to the only point. Yes, we are never seeing my 40 years life or 20 years of life or 10 years of life. Start making way that we are learning something new every time. It may be possible that not everything what is predicted will be 100% true tomorrow. And it's not always the same way. It is not a mistake like 100% every time. So something has to come out, and that's why we need to be more futuristic. I feel that is fine, but as mentioned by Buche sir, that it should not be too much and just should not be get diverted from your mind saying, okay, this is mentioned, hypertension should be okay, because that will give some wrong message to everybody around. So to some extent, yes, it is possible that I recently have my friend who has got in hypertension after having the surgery, and BP was at systolic of 70s and mean of less. He survived. So it is not like that everybody will be having the hypertension and they suddenly die within minutes. If other parameters are maintained, then there is chances to go up. And obviously, how to go up, we should know now. A lot of studies have mentioned that giving too much fluid, it is harmful. And now everybody agrees that less fluid and starting inotropes will be a better choice. Regarding the inotropes, obviously there are a lot of contrast still between the person to person and the same person at different timings. So again, we have to go tighten according to what we know, what our guidelines tell us, and what our experiences from previously. We should take it in mind. regarding cytosol and all others, one how coffee used by a lot of times in the adults. And obviously, there are very limited experience. But certain people have tried using certain similar modalities and they have noticed some improvement in some cases, not in every case. So whether it should be used blindly, I will say no. And definitely the AI is going to help a lot to us, everybody, and we are hoping for the same. And if we have data from all the different people's, AI is going to change this management. So far we are okay, whatever we learn, something new we are learning today, and definitely there are oppositions and also there will be the futuristic things which may we come to know only when we are in the future. So let's hope for the best and try our best way. What you are doing at a real time, it is correct. What I always feel in the ICU care, presence of yourself there is important.
Yes.
Yeah.
Thank you, sir. Thank you very much. And means we must thank Dr. Meenakshi Sheikh, sir, for selecting this article, which threw so much different aspects in pediatric critical care, and we are all grateful to him. Is sir here now logged in? I think there is some parallel meeting going on, and so most of the pediatrician might have attended that also. Any other questions? Dr. Jay, or shall we go for vote of thanks? Our secretary, Raigad IIP, Dr. Ajay Kodi is already there, and it's 10:45. Dr. Ajay, please
Yes,
do the
ma'am.
honors. Yeah.
Thank you, ma'am. It was a wonderful session. I thank everybody. First of all, our chief guest, Dr. Vasant Khalatkar sir, and guest of honor, Dr. Neelam Mohan, ma'am. Thank you very much for your blessings. Thank you for sparing your time. Next, our presenters, two presenters, Dr. Aishwarya Gupte and Dr. Sachin Jangam. Thank you for the wonderful presentations. Then our experts, Dr. Sanjeev Joshi sir, Dr. Vishram Buche, Dr. Mahesh Mohite sir. Thank you for your expert guidance on both topics. Then next, Dr. Jay Bhandarkar sir, the founding father of Journal Journey, as I learned a few days ago only. Our mentors, one lovely mentor, Dr. Gangolia sir, Dr. Dabatkar sir, thank you for your guidance. Dr. Meenakshi Sheikh sir, Dr. Mohanty sir, thank you for the selection of topics. And last but not the least, MOCs and the heart and soul of Journal Journey so far. And even henceforth, I am sure Dr. Chitra ma'am and Dr. Neha ma'am. Thank you both. If I have missed anybody, I apologize. And happy Doctor's Day to everybody. We deserve it, I think.
We
And
must thank
good night,
Pallavi
everyone.
ma'am. We must thank Pallavi ma'am for giving such a good technical support for last 4 years.
Yes. Sorry. Thank you, Pallavi ma'am. Yeah.
Dr. Pallavi, okay. Dr. Pallavi madam now.
Yes, Dr. Pallavi ma'am. Sorry. I joined in a little late. So again, I thank everybody for the wonderful session. Till the next time we meet again on yet another session to continue this great journey. Good night, everybody, and take care. Thank you.
Yeah.